Guys, so we'll go ahead and get started on chapter 14. This is over shock. Now, the good thing is this should be a little bit of a review for the most part, but we're going to dive even further into the pathophysiology of shock. Remember, shock is just a hypoperfusion of cells. So we'll dive into each of these just a little bit further, talk about some of their treatments. As I've said before, when you hear the same thing said over and over again in a course, that should set off lights and sirens in your head, and you should think, this is important. I should actually know this. So make sure that you actually know this. And if you have any questions, just reach out to one of us and we'll certainly help you, okay? So let's go ahead and get started. So as we know, shock is a state of collapse and failure of the cardiovascular system. The body will try to maintain its homeostasis in the early stages of shock, and we see this often, and we'll talk about what that looks like. But eventually, if the body can't compensate, the blood circulation will slow and eventually it'll cease. And when blood flow ceases, what is that called? Cardiac arrest, right? So that would be a cardiac arrest. So we can die from shock. Interestingly, shock occurs for a variety of reasons. Shock's kind of like an umbrella term. There's a lot of things up underneath it. So it could be from medical or traumatic or even psychogenic or whatever. Shock happens for a lot of different reasons. So we as pre-hospital professionals are always looking for the signs and symptoms of shock, and we're trying to treat reversible causes of shock whenever we can. And there's a lot of times that we can. There's sometimes we can't. But we should at least be able to recognize the signs and symptoms of it, okay? So remember, shock is simply defined as hypoperfusion. Shock is simply defined as hypo, which means low, perfusion. Well, what's perfusion? Perfusion is circulation of blood within an organ or tissue in adequate amounts, right? And what's the greatest indicator of perfusion? Doesn't require any expensive equipment. Capillary refill. Capillary refill, remember? We push on our finger, right? Should we go back to normal in less than 2 seconds? Capillary refill is a really, really good indicator of perfusion, okay? So there's quite a few formulas, not quite a few, there's a couple formulas in this lecture that we do got to know, but they're very simple. It's not crazy algebra or anything like that, so here we go. So cardiac output, think about that word, cardiac output. How much is your heart putting out, okay? Is the volume of blood that the heart can pump per minute, okay? So factors that affect this is myocardial contractility. Remember, the myocardium is the actual muscle of the heart. How well is the muscle of the heart contracting? And then preload and afterload can also affect this as well. So let's talk about these terms. So let's just draw a heart, right? So we know that blood comes in through the vena cava over here, okay? And so this is the inferior vena cava. This would be like the superior vena cava. But what's happening here is this is preload, okay? Preload is what's going to make it down into the ventricles, down here, to what the ventricle, so like that's how much is in the ventricle as it's opening up and it's filling. How much load is in the ventricle prior to the contraction? That's preload. What affects preload is for the most part blood volume and venous return, right? So how much blood is making its way back to the ventricle, okay? That's preload. And then we could ask, on the other hand, what's afterload, okay? Afterload is what does the ventricle have to pump out against, okay? So we know we have an aorta, and so the aorta will branch off to all these different things. And basically how tight that is squeezed down determines afterload. So think about this. The ventricle pump, right? But it opens up, okay? And then how much blood is going to sit in this ventricle? That's preload, okay? Ways we can affect preload is with medication. We could dump IV fluid into the patient to increase preload, right? So that's preload. And then right as the ventricle starts to contract, what is it contracting against? What is the afterload? What is it contracting against? Namely, it's going to be systemic vascular resistance, right? SVR. So it's going to pump against the vasculature, the vessels. And so if you have hypertension, right, the vessels are all squeezed down, then afterload's going to be increased because it's going to have to pump that much harder to escape the right ventricle and go through the aorta, or sorry, the left ventricle, and through the aorta and up to your head and down to your big toe. So that's preload and afterload. Very important you understand the difference between those, okay? Easy formula, what's cardiac output? I just told you, right? This is how much your heart puts out in a minute. So this is going to be heart rate times your stroke volume. Now, you're not going to know stroke volume without using a special machine that we don't have on the ambulance. So if they ever ask you to figure this out, they're going to give you what stroke volume is. It's done by a machine that we don't have. So let's just say the stroke volume, let's say the heart rate's 100 and stroke volume's 200, right? You could multiply that and that's going to be 2,000. So that's 2 liters. Is that right? Yeah. So that's about right. So just be aware. That's how this is calculated. Stroke volume. So what does that mean? It's 2,000 milliliters, or I'll write it out. 2,000 milliliters or 2 liters. So that says that every minute the heart's pumping out 2 liters of blood. Okay. Then the blood pressure. So what they're saying? What's the formula to, like, what makes up blood pressure? Okay. And so blood pressure is your cardiac output, as in this number, right? Multiplied by the systemic vascular resistance. And that's what I just told us. And guys, always break down these words. What is systemic? The whole system, the vessels, and how much resistance they provide. So how tight are the vessels within the system squeezing down? And so we take that along with cardiac output, and that's blood pressure. And that's why we measure blood pressure clinically, because it tells us more than just blood pressure. It can help us give an indicator of cardiac output and systemic vascular resistance. And we look at this along with a couple other parameters like heart rate, and we can kind of figure out, oh, this is this type of shock or that type of shock or whatever. So that's kind of helpful. There's a formula down here to help us get MAP. I don't know if y'all would necessarily need to know this, but the thing about, so this is mean arterial pressure, okay? And so basically what they do is they take so this is a time-based formula, and then so we know that it takes God, why am I having a brain fart? It takes the oh gosh, I'm sorry guys, it's a time-based formula. So the body is in diastole twice as long as it's in systole. That's what I was trying to spit out. So you use that in a formula to figure out what is basically the mean arterial pressure, meaning how much pressure is the vessel under on average. And so that's where they use this formula. You'll see this on the monitor. I'll just give you an example of like 120 over 80, but over here you'll see a number of like 88. Okay, and this 88 number over here, usually you'll see this on LifePak monitors. That's the MAP. That's the mean arterial pressure. Okay. Now, the autonomic nervous system is the automatic, parasympathetic, sympathetic. It's the 2 chains of it, nervous system that we don't really think about. And so it has a major control in the cardiovascular system both ways. So remember, the sympathetic nervous system, the fight or flight, we got to go fight a bear. Your heart rate's going to go up, your bronchioles will dilate, right? Your eyes will dilate. You're about to go fight a bear, so you want to get all the blood, all the oxygen, all the light. Okay? And conversely, the parasympathetic nervous system, if it's activated, it causes mainly bradycardia on the heart. It will cause the heart to slow down. Okay? And we can stimulate these in different ways, and we'll talk about what that looks like. But, so of course, we've talked about this. It's regulated from the upper part of the medulla oblongata, right? It's part of the brainstem off the water boy. The sympathetic nervous system prepares the body for physical activity during a stressful situation. So again, you could imagine if you're about to get into a fist fight in the girls' bathroom or the boys' bathroom, whatever, in high school, like what's going to happen to your heart rate? You're just going to start beating real hard, like you're getting ready for a fight. So we've talked about this. Sympathetic nervous system, fight a bear, fight or flight, right? And the parasympathetic nervous system, rest and digest. Okay? So with that said, we have 2 drawings here. Which one of these is going to be the parasympathetic nervous system versus the sympathetic nervous system? Right? So this is the sympathetic nervous system. This guy's ready to fight a bear, right? He has increased heart rate. His heart's beating faster. It has a better conduction. So it's chronotropy, inotropy, dromotropy, right? All of that's increased in the heart. The pupils are dilated to let all the light in to fight the bear. His arteries are constricting down. His lungs are dilating. His GI tract is slowing. You don't need to be processing your Taco Bell if you're about to get into a fist fight. So all that shuts off or slows, okay? And quite the opposite happens when the parasympathetic nervous system kicks on, right? You would have a decreased heart rate. Your heart's not going to beat as fast because you're kind of just ate a bunch of rice and pasta and you're real tired and worn down. And so your pupils will kind of constrict down because you don't need a whole bunch of lights. You want to sit there and rest, right? So the GI tract is really going to kick up faster when the parasympathetic nervous system is activated. Now, something to point out is I make it sound like there's a dichotomy between the two, right? That one's activated and the other's not. It's not true. You need to understand that one's in dominance over the other. Okay, usually they're in equilibrium or in somewhat equilibrium, but in these scenarios where there's obvious differences between the two and they're not in like an equilibrium, is one dominates the other. One's never completely turned off. That would be death, right? But if you're about to fight, it just the sympathetic nervous system will dominate the parasympathetic nervous system. So these systems are constantly battling each other and going back and forth, and occasionally, when needed, one will dominate. So if you, like I said, if you eat a bunch of rice and pasta, the parasympathetic nervous system will dominate, and that's where you're going to get these effects. Okay. So, what are sphincters? Remember, sphincters are the little donut-looking things, muscles that sit on tubes. You have sphincters in your throat, and you have sphincters in your rectum and your stomach, and all these places. And so they're just round muscles. And basically, how we regulate blood flow is So we'll draw this out for you. Is if this is a vessel, there's a little muscle here. And so if that's what it normally looks like, if this sphincter needs to close down, it'll go like this. It'll squeeze and it'll make the lumen a lot smaller, right? And so that's how we control that. And so that's normal. We have sphincters on our capillary beds. Okay, remember capillaries is the junction of the artery and venous system. And where could we see a capillary really easily? In our nail bed, in our fingers. Okay, and basically what determines how tight these are going to squeeze down, whether they're going to be leaky or not, it's based on the cellular need. So, if it's really cold outside, your body's going to shunt blood back to your to your torso, and so the cells aren't going to get it. So just be aware of that, okay? Um, so this is accomplished by vessel constriction or dilation. You just said that. Manual perfusion is accomplished by heart, blood vessels, and blood working together. So important point. Perfusion's not just capillary beds, it's not just the heart, it's not just the lungs doing diffusion, right? This is a system, right? Systems have to work together. And so at any point in the system, something can fail or go wrong. But as a generality, this is a system and systems work together, okay? So respiration, oxygenation. Oxygenated blood will pass through the alveolar wall into the pulmonary capillaries. And then diffusion of oxygen from the alveoli into the blood. And then carbonic acid will breaks down in the lungs and carbon dioxide is exhaled. So remember me telling you, where is oxygen carried in the blood? It's carried in hemoglobin, which is part of the red blood cells. And then carbon dioxide, the byproduct of cellular respiration, is carried in the plasma in the form of carbonic acid. Remember, CO2 is acidic because of carbonic acid. And an enzyme called carbonic anhydrase will break it down. So that's a little bit more advanced that we don't particularly need to know at the EMT level. Now, shock is complicated. It's not complicated, but it's multifaceted. There's a lot of little pieces to it, right? But it can happen because of poor or inadequate cardiac output, right? Decreased systemic vascular resistance, so our capillaries will become leaky, okay? Or the inability of the red blood cells to deliver oxygen to tissues, okay? It can happen for more reasons than that, but that's pretty big reasons with why this can happen. So as I described when it's cold outside, where we'll shunt blood from our periphery into the central areas, the torso, the body will attempt to compensate by shunting blood flow from more tolerant organs to vital organs. So your fingers, they like blood, but they don't like blood near as much as your kidneys and heart and head, right? So your body will say, wow, we should shunt blood and shock even. So not just cold, but shock. It'll shunt blood from the periphery into the core. And so the reason that I say check capillary refill on the finger and on the core is you'll see a difference if this is happening. So it might be 8 seconds on the big finger, on the pointer finger, and it might be 4 seconds on the midline. or like the chest or something like that. So just be aware that that's a pretty common phenomenon. Okay, so we've talked about this a lot, but I'll draw it out real quick. So let's start here. Okay, so we'll start here with a little cell doing its job. Okay, so a cell does its, or let me start here actually. All right, cell does its job. What's the byproduct of cell respirations? It's CO2, one of the many, and oxidative phosphorylation, it's CO2. So CO2 is picked up in the capillary beds and carried through the venous blood through a vena cava. In this case, we were talking about the head, like the brain, so is the superior vena cava. It goes through the right atrium, through the tricuspid valve, remember, try before you buy, to the right ventricle, and through the pulmonary artery. Through the pulmonary artery, CO2, this is venous or deoxygenated blood, will diffuse at the alveolar beds, alveolar capillary beds, and it'll drop off the CO2 and pick up oxygen through diffusion, right? And so that'll pick up the oxygen, carry it through the pulmonic vein into the left atrium, right there, and through the left atrium, it'll go through the left ventricle or the bicuspid or mitral valve to the left ventricle. From the left ventricle, it'll be pumped out through the aorta and then down back through to the systemic circulation here and here. Okay, again, you have to be able to explain that to me. You need to know how to trace a drop of blood from a cell back to a cell. It's very important. Okay, and it's not complicated, and I encourage you to not just blindly memorize the order, but to be able to truly explain it with what's happening. Okay, you'll get a lot further, and it won't take that much more effort to be able to explain it, as opposed to just be like, you know, superior vena cava, right ventricle, tricuspid, right? Like, explain it. Okay. Now, they have this thing called the perfusion triangle, and basically you need all three of these to function optimally for adequate perfusion. And if there is a mess up in any of these, you'll end up with pathology. And sometimes it's multiple of these is where we have failure, and that's where the shock can arise. So if there's with the heart, right? So damage to the heart by disease or injury decreases the ability of the heart to properly function as a pump. Therefore, it cannot move enough blood through the body to support perfusion. Okay, so that makes sense. If the heart's not beating very effectively, you're not going to deliver as much blood to the up to your toe and or up to your brain and down to your big toe. Further, the blood vessels themselves, the container function, right? So sometimes they'll call this the container. If all the blood vessels dilate rapidly, the normal amount of blood volume is not enough to fill the system or provide adequate perfusion to the body. Where do we get scenarios where we get dilation of the blood vessels, right? So this could be sepsis. This is a distributive shock, by the way. So you can end up with sepsis or anaphylaxis. You could also end up with neurogenic shock. In all of these disorders, the vessels dilate. And when they dilate, the container gets too big. Okay? And this type of the heart, it's cardiogenic shock. How do we get this? This is from like a myocardial infarction, also known as a heart attack. You could also get this from like arrhythmia. Okay? Now, blood, where does this mess up? So the blood is the content function. If there's enough blood or plasma loss, the volume of fluid in the container is not enough to support the perfusion needs of the body. So how do we have blood loss? Well, quite obviously, this would be hypovolemic. What does hypovolemic mean? That means low volume. So this could be hemorrhagic. Whoops. This could also be just straight up volume loss from like vomiting and diarrhea. Okay, pooping blood, something like that. So just be aware that this is more than, or straight up dehydration. This could happen, hypovolemia, like severe dehydration, like diabetic ketoacidosis, like an osmotic dehydration or something like that. You could end up with a hypovolemic shock. Okay. So blood is obviously the vehicle for carrying oxygen and nutrients. What does blood consist of? You know, plasma, red blood cells. Red blood cells are made of hemoglobin. Hemoglobin is what actually carries the oxygen. Okay. So it contains red blood cells, white blood cells. What are the white blood cells? Those are the ones that respond to infection, and then plasma. Okay, so our blood is designed to clot, whether there's an intrinsic or extrinsic activating mechanism, which means like basically if there's an internal or external cause for us to make a blood clot. It will do it. It uses different pathways, and it's formed, and so we'll create blood clots, right? And it's formed depending on retention of blood, changes in the vessel's wall, and the blood's ability to clot. So, if you don't know how blood clots work, I'll just tell you real quick. So, if this is your blood vessels, and these are the cells that line the blood vessel wall, not drawn to scale, and so these are like little individual cells. Basically, when one of these get damaged, it trips us the clotting mechanism internally, and so it signals all these different mechanisms, and basically, long story short, it'll create the clotting factors will be activated, and so blood will start clotting, platelets will start aggregating, fibrin will create a mesh, and then that's how blood clots form. Okay, but what creates a blood clot is a tear in the cell wall. It releases this stuff called arachidonic acid. And let's see. Oh, so the body's neural and hormonal mechanisms are triggered when body senses falling pressure. Wait, the body's neural and hormonal mechanisms are triggered when the body senses a falling pressure. Okay, yes. So when we feel that like that we're having a drop in pressure, what's supposed to happen is the sympathetic nervous system should kick in, right? If it's falling, right? The parasympathetic nervous system should kick in to increase heart rate, to squeeze down on the vessels, right? To respond, okay? The parasympathetic nervous system controls involuntary functions. Okay, yeah, cool story, that's true, but it doesn't really relate to the treatment of shock. But what I do want you to know is this. That the sympathetic nervous system is what is going to kick in times of shock and really try to fix our problem. What are the messengers of the sympathetic nervous system? Epinephrine, dopamine, norepinephrine, mainly. Okay, and interestingly, we carry all three of those on the ambulance for shock, right? So paramedics administer these drugs for shock. So they're that important. We just give them a little extra epinephrine or norepinephrine or dopamine. Okay? So we compensate for decreased perfusion. So basically, we have these things called baro. Remember, baro means pressure. So baroreceptors are pressure receptors that will sense a decreased blood pressure and blood flow. So they're stretch dependent. So when they're not stretched, they send off a signal. And they'll say, okay, well, we're not as stretched, so we need to activate the kidneys, we need to increase the sympathetic tone, we need to do some things, okay? And so chemoreceptors are different from pressure receptors, but chemoreceptors measure shifts in the amounts of carbon dioxide in the blood. And what does carbon dioxide do in the blood? It makes it more or less acidic. So chemoreceptors are measuring pH of the blood, okay? Indirectly. And stimulation occurs when the systolic blood pressure is between 60 and 80 millimeters of mercury. So what's the systolic blood pressure? Is that the top number or the bottom number? It's the top number. Top number is systolic. So hypoperfusion, remember I just told you the kidneys will kick on. And so the renin, what's called the RAS, right? Renin angiotensin aldosterone system activates and it releases antidiuretic hormone. Well, if I tell you the word diurese or diuretic means to pee, what do you think antidiuretic hormone means? It means do not pee. So it's saying hold on to the fluid. Don't lose it. So that's what happens. Your body's like, oh, wow, we're losing volume. We should hold on to all the volume we have. Don't piss it out, right? So that's what happens. What's one of the many things that happens when RAS is activated, okay? So the first response mechanism is to increase the preload, the stroke volume, and the pulse rate. How do we increase preload? We increase volume. How do we increase volume? As paramedics, we can give IV fluid. They might trigger a thirst response in humans to where they'll drink some water or something like that. And of course, the pulse rate will go up. The autotransfusion effect allows the body to compensate for a volume loss of up to 25%. So we have like adults have like this is a liter bottle, 5 to 6 liters of blood in our body total, right? And so if you you could lose like one of these and be okay-ish, like it's not going to be a great day for you, but that's you would still be able to like kind of do okay with that. Some water sounded good. All right. The sun's annoying from these blinds. I'm sorry. Um, if hypoperfusion persists, right? So the shock continues. The myocardium, well, okay, think about this. If hypoperfusion, low perfusion occurs and it keeps occurring, it's not fixing itself, who do you think's going to get mad first, right? The brain, altered mental status, the chest pain, the kidneys, we won't have pain, but you're going to have damage. So, if the hypoperfusion and persists, you're going to end up with worsening myocardial function. Okay? Remember, myocardial is the heart, so it'll worsen. Why is that? You're decreasing the amount of oxygen to go to the heart, so it's not going to be able to work as well. Okay? It's also starving. The perfusion at the individual tissue level, it will decrease. You'll end up with leak of fluid from the blood vessels, sure. Perfusion to the brain and coronary artery decreases. I just covered that. That's going to be one of the first things that you're going to notice. It's going to happen systemically, but we're going to notice it there first. Typically, the cells will switch to anaerobic metabolism. What's anaerobic? Without oxygen. Remember, the cells can switch. They're just very inefficient when they try to do metabolism without oxygen, okay? You get a lot less ATP yield. And then we're going to start producing and dumping epinephrine and norepinephrine, okay? So they have what they call a pecking order, right? And so we can plan, the body plans out its shunt from blood of areas of lesser significance to areas of greater significance. So again, your body's like, yeah, fingers are cool and nice, but we're dying. So let's go ahead and shunt the blood from your hands and fingers to the heart or to the brain. So you end up shunting blood. Remember, shunt is when we move blood from one part of the area, from one part of the body to the other. We remember there's intrapulmonary shunt. I just talked about that in a previous video. Okay. So failure of compensatory mechanisms to preserve perfusion result in decrease in preload and cardiac output. Okay, yeah. So this is what happens at the cellular level. Okay, so shock-related events at capillary and microcellular or microcirculatory levels. So ischemia. This word ischemia means that it's starving for oxygen. Okay, it's not dead yet, but it's really starving. So cellular ischemia occurs with decreased perfusion. So I could break that down into layman's term. Cellular cells start starving for oxygen when there's decreased perfusion. Intuitive, that makes sense, right? There's regulation of blood flow. So the body will start regulating where it's going to be sending its blood and how tight it's going to be squeezing down to certain areas. You're going to revert to anaerobic metabolism. We can't stay on this very long, especially systemically. Acidosis serves as an indirect measure of tissue perfusion. Very important. So remember, the byproduct of anaerobic metabolism is lactic acid. And there's a very easy lab test where you can test lactic acid. And so if I have a patient and I get to the hospital and they run their labs and their lactic acid count is or value is very high, then you could assume, oh wow, they've been in anaerobic metabolism. Why are they in anaerobic metabolism? Probably because of some form of shock. Where else do we? So the where we commonly see this is in sepsis, okay, in infection, okay. So dysfunction of the sodium potassium pump will happen. So remember, if this is a cell, there's a pump that will pump sodium into the cell and potassium out, okay, and then switches it back, right? So it's like sodium in, sodium out, so potassium in, potassium out, right? So what happens is, since this is going against the gradient, right, the sodium potassium pump requires ATP. And where the heck do we get ATP from oxygen? If you're not getting oxygen, you're not getting ATP. And if you're not getting ATP, you're not getting the sodium potassium pump. So what happens? The cell will swell and it'll eventually lyse. It'll split open. So the cell will get bigger and bigger and bigger and bigger. And eventually, it'll lyse and it'll leak its contents out into the blood. There's also lab tests that we use to test for that in the hospital. So that's an important phenomenon that we need to know, that when cells start to not start, when cells do not get enough oxygen to produce enough ATP to keep up with the sodium potassium pump, they swell. They can swell so much. Remember, water follows salt. If you're not pumping the salt out, right, they will swell so much that they will blow. They'll explode. Okay, and that does happen often. That's a hallmark of pathology, actually. So the capillary microcirculatory levels, we're still on this, right? Um, The cellular flooding releases lysosomal enzymes. That's what I just said. It'll leak. It'll lyse. It'll blow up. Okay. Continuing buildup of lactic acid and carbon dioxide acts as a potent vasodilator. Well, this is bad because, interestingly, in acidic environments, vessels dilate. Okay, and so as you build up lactic acid, acidic, and carbon dioxide, acidic, vessels dilate. And in cases of shock, you don't really want vessels to dilate. You want them to squeeze down. So it further adds to this problem. Um, in forms of pathology and physiology in normal days, this is a good thing, but in pathology, especially in the case of shock, it's very obnoxious and it's hard to handle. Okay, now white blood cells and the clotting system become impaired. Why is that? The liver creates clotting factors, and so the liver's going to be like, I'm not wasting energy on this shit, right? So they're just not going to work, and then not only that, they're dependent on like the components of the blood to all be there and be working properly. It's complicated, but one thing is the liver will not work well. Okay. Also, cortisol will be increased in this time, which I told you shuts off or helps shut off white blood cell production, right? So that's why we give steroids to immune suppress people. DIC can occur. This is complicated, but this is disseminated intravascular coagulation. And so DIC is micro blood clots. And so what this looks like is these are individual cells. You'll end up with a little clot right here, okay? And so it's disseminated, right? It's inside the vessels are coagulating, and this is because of the time of stress and cellular injury. And so what happens is red blood cells will try to go through here, and then these red blood cells will actually get sheared in half, and that's called a schistiocyte. And so just know that DIC is a consequence of hypoperfusion. We see DIC most commonly where you'll see this is in sepsis. It's a late finding in sepsis. How does this present? I'm glad you asked. It'll present with a patient that is bleeding from their IV line, right? So basically, like your paramedic partner started an IV and they're like just bleeding around the IV bandage, right? With a good IV in place. That's like a hallmark academic way they'll present that. They'll also have a rash where it looks like under their skin is bleeding because it is. Okay, so they could have like purpura or petechia, more so petechia. Now this can progress, so we're progressing. This is getting worse and worse and worse, right? So I told you DIC, these little microvasculature blood clots, bad. Okay, not good when that happens. This will cause MODS, right? So what's MODS? MODS, right? This is multi-organ dysfunction syndrome, okay? And so basically what happens in MODS is you end up with two or more organ systems failing because of this. And so this occurs, you see this a lot in sepsis, it's talked about a lot in sepsis. It happens in other cases, right? But this occurs when injury or infection triggers a massive systemic immune, inflammatory, or coagulation response. When do we get a massive, exaggerated immune, inflammatory, and coagulation response? This coagulation response is referring to DIC. Remember, disseminated intravascular coagulation. And what's happening here is this sounds like this is describing sepsis. Remember, sepsis is overwhelming infection that has overwhelmed the body. So what happens is you get complement activation, and the coag system will activate, and the kallikrein and kinin system. What these are not important really for the most part. Just know that the body just starts throwing everything it can, right? And it's almost like a sad story, right? It's like the body has this big infection. It's like, oh wow, we should do some inflammation, and it doesn't turn on enough inflammation. And then when it's too late, they're like, fine, give it all we got, give it all the inflammation, do everything we can. And in this exaggerated response to try to fix the body itself is actually killing the body, and it's what causes these people to die. So sepsis is very fatal, very fatal. It's the leading cause of death in the United States by far, one of the probably the top 5. So MODS, how does this present? Right? How does multi-organ dysfunction syndrome present? Okay, hypotension. I want you to know hypotension is a late finding in shock. Hunter Harbold will say that again. Hypotension is a late finding in shock. Okay, so what does that mean? I don't want you to look at a patient who's obviously in shock and be like, oh, their blood pressure is 135 over 82. They're good. No, 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 no. Their heart rate's 140, right? Their SATs are 93%, right? They have an altered mental status. They're complaining of shortness of breath and chest pain, right? They're dying. Blood pressure is a late finding. It's the last thing that will drop, okay? Of course, in mods, they're going to have insufficient tissue perfusion, uncontrollable bleeding. That's part of the DIC. That's where I told you they could leak around their IV catheter. That's the classic example of that, okay? Multi-system organ failure caused by hypoxia, yes. Tissue acidosis, yes, okay? And severe local alterations of metabolism, yes, okay? They can become respiratory impaired. This acidosis can cause them to try to breathe faster to blow it off, but that's complicated. But insufficient concentration of oxygen in the blood can produce shock. Okay, we've seen this, right? If I were to change somehow your atmospheric oxygen from 21% to 10%, you're going to get pretty shocky pretty quick, right? So, of course, right? And we could see this with poisoning and carbon monoxide, right? Poisoning may affect the abilities of cells to metabolize or carry oxygen. Carbon monoxide, the byproduct of production, CO, does just that, right? It binds to the hemoglobin to where actual oxygen can't bind as easily. So we decrease the carrying capacity of hemoglobin for oxygen, so we end up with shock, okay? So what are the signs of carbon monoxide overdose? Right? Guy locked himself in the car, in the garage with the motor running for 2 hours. Right? So it's going to be cherry red skin, a high pulse oximetry reading, altered mental status, tachycardia, tachypnea. Okay? That's it. Well, among other things. But all right, anemia. We see this a lot. So there's a lot of different causes of anemia. What's the most common cause of anemia in the United States? It's iron deficiency anemia. So the only way that your body can intake iron, well, it's difficult for your body to intake iron. Let me start with that. The only way your body can lose iron is through blood loss or sloughing of the skin cells. So women who menstruate tend to lose blood every month. If they have abnormally heavy or periods or long periods where they're bleeding from menstruation, then they can end up with anemia, true anemia from blood loss, and then also they tend to be also iron deficient. But I'll say that again: the most common anemia in the United States is from iron deficiency anemia. It's usually from poor diet. And so, and worldwide too, I think it's iron deficiency anemia. And so, but this is very treatable. You just take an iron pill. But why am I telling you iron deficiency anemia, Hunter? Shut up. No, it's because if you don't have iron, your body cannot produce red blood cells that are the right size or enough of them. So you have to have iron to produce red blood cells. If you're losing iron through heavy menstruation or you're not intaking enough iron, then you can end up with severe anemia. Okay. How do we test for anemia in the pre-hospital environment? One thing you can do is look at the lips and the gums. If they're particularly pale, that you might think that they could have anemia, you could ask them about their periods. If they're a heavy flow or long, like 7-10 days or more. Another way too is you can look at the conjunctiva underneath the eye. So you can take their eye and pull down. You should see this on yourself. It's pretty red for you. That's because there's red blood cells underneath there, and you can see that it's red. But on an anemic patient, you'll see that it tends to be more pale. It's more white-ish in color. So that's something to be aware of. A good way to test for anemia, just pull up underneath the eye, and if it's not red underneath there, you might be thinking anemia. It doesn't matter if they're white or black, by the way, in skin color. It's just, you can just look underneath the eye. So that's why that's a good test. Anemic patients that are white tend to be pale in color anyways, but I mean, I think I look pale, and I'm not anemic, so that I know of. All right, so let's keep going. Causes of shock. So, of course, this is where we get into the good stuff. We could have from bleeding, or respiratory failure, or acute allergic reactions, or infection, okay? So remember, we can have a pump problem, we can have a blood loss, a fluid loss problem, or we can have a poor vessel problem. We could really have a combination of these. So remember, pump failure, what do we call that? Cardiogenic shock, okay? Heart attack, trauma to the heart, obstructive, that's a little different. It's not cardiogenic, but that's from like a large pulmonary embolism or pericardial tamponade or from tension pneumothorax, I'm sorry. Now, poor vessel function, this is from sepsis, infection, right? The overwhelming infection will cause the vessels to dilate. Drug overdose, like narcotics, that can happen, not as common. Spinal cord injury, that can happen, okay? If you completely transect the spinal cord, you will lose a good chunk of your sympathetic tone, so the parasympathetic system will dominate, and then your vessels will become leaky because the parasympathetic nervous systems don't cause the vessels to squeeze down, okay? So that's one way it can happen. Oh, what's the example of how that happens? Someone jumps off into a pool that's only 2 feet deep and snaps their neck or something like that, or motorcycle wreck. I'll tell you too. Well, we'll talk about this. There's slides on each of these. Anaphylaxis. Remember the extreme allergic reaction to a foreign substance. For me, that's tree nuts. For you, it could be uh, bees, pecans, cashews. I don't know. So it could be a lot of different things for different people. And then lastly, low blood volume, right? Straight up blood loss. You're shooting blood across the post office from your leaky artery, okay? Uh, blood loss, blood loss or fluid loss from GI tract, nausea, vomiting, diarrhea, okay? You could also lose blood in your vomit or in your poop, okay? So you're going to expect shock if the patient has multiple severe fractures. Um, Siri. Multiple severe, shouldn't say her name. Sorry. Multiple severe fractures, abnormal abdominal or chest injury. Okay. Spinal injury. Now we'll say it has to be pretty severe spinal injury, not just a straight up fall on the ground. We'll usually cause that. Severe infection. So if you have someone with fever and an altered mental status, it needs to be considered sepsis until proven otherwise. Right. Major heart attack, of course, cardiogenic shock. Okay. And anaphylaxis. Hives, urticaria, shortness of breath, wheezing, tachycardia, hypotension. Those are signs of anaphylaxis. Now, let's talk about the different types of shock, and we're getting to the meats and potatoes of this lecture, so hang with me. Hypovolemic. Break down the word, guys. Hypo, low, volume, volemic. Okay, hypovolemic shock. It's shock due to inadequate blood loss or blood volume. It could be hemorrhagic, as in you're losing blood, it's shooting out of your arm, you've been shot in your arm, or you're pooping blood or vomiting blood. Okay, it can also be from your pooping just straight up Taco Bell and you're vomiting straight up beer. Okay, you can lose volume both ways. Okay, so keep in mind, hypovolemic does not just mean blood, it means components of blood like plasma and fluid. Okay, so there's a distinction between the two. And in fact, you don't even know how many patients we see in the ER and on the ambulance, they're hypovolemic because they've been pooping their guts out for 3 days, right? So their shock is from pooping too much, diarrhea, vomiting, okay? It's more common than we run more patients that have hypovolemia due to fluid loss from vomiting and diarrhea than we do from blood loss, like much more common, okay? Non-hemorrhagic shock occurs when fluid loss is contained within the body. This would be like you can see this in like peritonitis, maybe. I mean, you can see this in like a really large abscess. This would be more rare. I mean, you could also see this in like a third spacing, maybe like lymphedema or something. But this is more rare. Okay. Okay, so abnormal loss of fluids and electrolytes. So, straight up dehydration. I tend to neglect that. Someone who's just not drinking enough water, right? They went running a race and they're not drinking enough water. They're sweating out their volume, okay? So from GI loss, I've covered that extensively. Excessive sweating, okay? Internal losses like peritonitis, pancreatitis, or an ileus. Ileus is a slowed bowel, like a lazy bowel, okay? Like lazy guts, okay? Plasma loss from burns, okay? When we have burns, we tend up with these really gnarly fluid shifts that can cause a plasma loss, a fluid loss. So the hallmark of burn treatment is actually fluid replacement. Same thing with like someone that has like a surgical drain or a drain or granulating wounds. So like granulating wounds would be like a really wicked scarring wound, like it scars, okay? Like a granuloma. Now, other causes could include ascites. Remember this word? We've talked about it. Ascites. It's spelt weird. Who gets ascites? It's people who have liver disease. And so, I'll draw it out. Okay, here's our patient, and there's the diaphragm. Well, what sits over here is the liver. Okay, so remember, this patient's right. And so remember, all the blood from, we'll just say all the blood from the guts, the small intestine, the large intestine, pretty much all of it, but not all of it, but pretty much all of it, will go through this thing called the portal vein. And the portal vein dumps into the liver. And if someone is an alcoholic and they have scarred their liver, like literally scarring, it's become hard. Cirrhosis means to scar. So they get a liver cirrhosis, or they've incurred a viral disease like hepatitis that causes scarring of the liver. What will happen is this liver becomes scarred, so fluid starts backing up in the portal vein. Well, as it backs up into the portal vein and if the liver stops producing as much albumin, one of the ways this can occur, besides like this sequelae that I'm kind of jumping off into something, I'm talking about something we probably don't need to talk about, but just realize when there's damage to the liver, you will end up with it won't produce enough of this protein called albumin, one, and just straight up blockage of the highway. And so what happens is they'll end up with this big fluid watery belly. So it's like a beer belly that's huge, like that's really watery too. In fact, you can feel it splash. If you have the patient, you can feel it splash. If you have the patient turn side to side, it's called a succession splash. They'll have this really big belly, and sometimes the belly's hard. It may not feel like water because it's so filled with water. So just be aware that's ascites. Okay, I'll talk more about pathology of liver cirrhosis later. Diabetes insipidus. So keep in mind when we talk about like diabetes mellitus, right? We're talking about diabetes that has to do with sugar. Diabetes insipidus is different. Diabetes insipidus is when you don't have enough of a antidiuretic hormone. And so basically you lack the hormone antidiuretic. So break down the word to remember diuresis is to pee. So you lack the hormone that says don't pee. So what are you going to do? You're going to pee a lot. If you lack the hormone that says don't pee, you're going to pee a lot. So when they pee a lot, they lose a lot of volume. Okay? That's diabetes insipidus. How does this occur? Typically from head trauma. It's produced in your pituitary, and that stalk can get severed, and so you can end up with diabetes insipidus. Okay? And osmotic diuresis, secondary to hyperosmolar states. What? Okay, let's talk about this. Remember, diuresis means to pee. So osmotic diuresis, right, from an hyperosmolar state. So you're too osmolar, right? Hyperosmolar. So what has an osmotic pool? Glucose. So if someone's blood sugar is 500, right, it's going to pull the water out of the cells because it's hypertonic, and it's going to pull water out of cells, and then it will cause this it'll cause a fluid loss. So the hallmark of diabetes mellitus actually is dehydration. So that's what happens with osmotic diuresis is it's diabetes with high blood sugar. When their blood sugar is high, it will cause an osmotic pool, which will cause severe dehydration, life-threatening dehydration. So the earliest signs of shock are going to be restlessness, anxiety. The patient could feel thirsty, right? That's part of the RAS system kicking on, renin, angiotensin aldosterone system, right? They can feel nauseated. They may feel like they need to vomit, okay? Why is that? The nausea vomiting, right? It's turning off of the parasympathetic nervous system. You're kicking in the sympathetic nervous system, okay? They could be pale, cooled, clammy, and the skin become mottled. So what's the medical word for cool, clammy skin? Right? Sweaty skin. It's called diaphoresis, so the skin's diaphoretic. The reason for this is there's several reasons. The easy reason is your body will shunt blood from your skin. Let's just say that. Okay, for now, there's more reasons. The heart will speed up. What's the word for a fast heart? Tachycardia. As blood or fluid continues, or fluid loss, I'm sorry, as blood or fluid loss continues, blood pressure will fall. That is a late finding. But Hunter Harbold said it here first. What's one of the first findings in shock? Altered mental status. Okay, it is a very early finding. Now, what's cardiogenic shock? So cardiogenic sounds like what it sounds like. It's heart shock, right? The heart's messed up. Something's wrong with the pump. And this can happen for a variety of reasons. The first one, let's just start easy, arrhythmia. If your heart's beating 20 times a minute, that's a problem, okay? If your heart's beating 280 times a minute, or trying to, that's a problem, okay? So arrhythmia can create cardiogenic shock, sure. What also can create cardiogenic shock is a heart attack. So we know the heart's just a big muscle, and so if this chunk of the heart just dies, right? This muscle is not going to pump very effectively, hence cardiogenic shock, right? It's a problem. So cardiogenic shock caused by inadequate function of the heart, so the pump has failed, and it develops when the heart cannot maintain sufficient output. So the heart will try to compensate as long as it can, and as it fails in compensating, the symptoms will progress. Okay, and as afterload increases, cardiac output will decrease. What? Okay, so what happens is in cardiogenic shock, the body will try to let me think about this. The body, yeah, it will try to squeeze down on the systemic vascular resistance, which will increase afterload. Um, and the consequence of that, the the heart doesn't have to pump as hard to maintain cardiac output. So I'll say that again. The systemic vascular resistance will the vessels will clamp down to try to make it easier for the heart. Okay, and so that will it's one way it'll try to preserve itself. Now, with that said, here's what happens in cardiogenic shock, and this is a hallmark, is this thing called pulmonary edema. Okay, this happens in heart failure, especially congestive heart failure and left-sided heart failure. So when the heart fails, cardiogenic shock, when the heart fails, fluid will build up within the lungs, the vasculature of the lungs. And as it builds up, you increase this annoying term called hydrostatic pressure. You're increasing the amount of like water pressure within the vessels. And sometimes that water pressure will build up so much, it'll kind of leak out of the capillaries. And when it leaks out of the capillaries, it finds a home in the alveoli. Because remember, the capillaries are surrounding the alveoli, so it sits in the balloons of the alveoli. And then you end up with this annoying thing called pulmonary edema. And what sound does a pulmonary edema make when we listen with our handy dandy stethoscope? What sound does it make? I'll give you some options. Is it wheezing, stridor, rhonchi, or is it rails and crackles? It's rails and crackles. It sounds like they're breathing through a sonic straw and a Coke, right? It sounds like that because they are breathing underwater because there's literal fluid in their lungs, okay? Pulmonary edema. So just be aware when you see the word, for the most part in an adult, especially an old adult, if you hear the word crackles or rails in your vignette, you need to be thinking, there's something wrong with the heart, because that's typically how it'll present. Now, crackles and rails can happen in other pathology, but I'm just throwing a generality out there for y'all. Now, what's obstructive shock? So think about it. If someone's obstructing something, what are they doing? They're blocking it. Like they're physically blocking it. If some wacky protester is sitting on the interstate, obstructing the interstate, right? They're obstructing, right? They're blocking the interstate. So there's only a few times that this type of shock happens. And how this will happen is three examples that I've talked about before, but I'll hit them real quick. Well, remember, we have the heart, and around the heart is a sac called the pericardium. And the sac is thin and it's leather-like. And what happens is normally there's a little bit of fluid in between the heart and the sac as a lubricant. Well, if you have a large amount of blood, for whatever reason, end up in this sac, or fluid end up in the sac outside of the heart and in between the pericardium, it can squeeze on the heart because this sac won't accommodate in time. So what will happen is it'll obstruct the heart from filling. It's physically obstructing the heart. Obstructive shock. These are all physical, by the way. Physically obstructing the heart. That's pericardial tamponade. Okay? How do we fix this? Paramedics and doctors will stick a needle into the heart and drain that fluid, or the heart sac, not the heart itself. Okay? That's called pericardial centesis. Now, moving forward, what's a tension pneumothorax? I'm glad you asked. So, this is when we have two lungs, right, and a heart, and they sit inside our little bitty chest cavity. Okay? And so, what happens is if one of these lungs pop, okay, for whatever reason, air will escape. And as it starts escaping, it starts building up and it starts pushing and pushing and pushing and pushing and pushing and pushing, and it creates tension, right? So break down the word. There's a pneumothorax, so air in the thorax, that's creating tension. It's a tension pneumothorax. And how does this present clinically? Absent or diminished lung sounds on that lobe. Unequal chest rise. This side of the chest will not rise as much. Tachycardia, tachypnea, low O2 sats, altered mental status, shortness of breath. Okay? So the problem with this They're normally not green, obviously, but there's vessels that run through the mediastinum, right through the middle of the chest. If this tension pneumothorax starts pushing onto these vessels and or the heart, then it physically obstructs the amount of blood flow that can get into the heart, so it decreases preload. That's a tension pneumothorax. How is this fixed? I'm glad you asked. It's a needle, goes right there in the chest, and it'll allow the air to escape through the hole that you just created. Or you can also stick your finger in there too, or a chest tube. So there's several ways to treat this. Okay. Now, moving over here. The last thing, pulmonary embolism. I've described this before as well, but we'll do it again. That's how much y'all mean to me. So we have the heart, right? Off the heart becomes pulmonary artery. Is this oxygenated blood in the pulmonary artery? No, it's not. What, Hunter? It's an artery. I know. It's deoxygenated blood coming off the right ventricle. And so it carries blood to the lungs. Okay? And so what can happen is a cross the road trucker, flight attendant, someone who just had surgery, someone who's bedbound, someone who's in a wheelchair can end up with a blood clot, usually behind their knee in the deep vein. It's called the deep vein thrombosis. What does that present as? Redness from the knee down, redness, swelling, pain. And so what happens is that thrombus, the blood clot thrombus, will bust loose, travel up through the vena cava, through the right atrium, tricuspid valve, right ventricle, pulmonary artery, and it will come lodge somewhere in the lungs. When it becomes lodged somewhere in the lungs, it is called a pulmonary embolism. And so if it sits within the bifurcation of the pulmonary artery, that's a saddle thrombus. It's universally fatal. And then but usually it'll jump off and it'll go into a smaller branch. That is obstructive, right? You're obstructing the blood flow to the lungs. Pulmonary embolism, okay? Pulmonary embolism. We also call these PEs, not physical education. Okay, so just know that's the three, a quick recapitulation on all of those. Now, distributive shock, a very common form of shock, way more common than these. This results when there's widespread dilation of small arterioles and small venules. Okay, it's probably worth knowing that it's the small boys, right? It's not like the big ones. It's the small ones, and it can also happen in the capillaries too. So, just think about this. If your vessels go from this to this, they've greatly increased in size, which means they've increased their capacitance, how much something, in this case blood, they can carry. So the consequence of that is when your vessels go from this to this, distributive shock, they can decrease preload. And when they decrease preload, you end up with shock, right? Your heart's not going to have adequate cardiac output to be able to pump blood up to your head and down to your big toe. So that becomes a consequence, okay? One of the other ways that this can happen is these can become leaky. So let me just draw this. Well, let me draw it like this. So normally this is like inside a vessel. These should all be touching. But what happens is when your body releases histamine, it pulls. It's a smooth muscle vasoconstrictor. And so what happens is it'll pull these little podocytes, these little muscles that connect each cells, and it'll allow not red blood cells, because red blood cells are like this big, won't allow them to leak through, but it will allow plasma and other fluid to leak out into the third spacing. So this is weird. You're like, what? The third spacing? It's outside of the vessel. So that's another way distributive shock causes problems. So it's histamine that causes, it pulls here, and so now you're allowing stuff to escape here. Okay, so that is a way that this happens as well. So again, neurogenic shock. So this is due to a damage of the nervous system that controls size and muscular tone of blood vessels. How this typically happens is complete transection of the spinal cord. All vessels below the level of the spinal cord will dilate. Why is that? Sympathetic tone is carried in the spinal cord, and if you completely slice the spinal cord open, besides having a bad day and paralysis, you're going to end up with an increased sympathetic tone or parasympathetic tone, and so you won't. The vessels who are normally like kind of like fighting with the sympathetic nerve system, now it's just the parasympathetic nerve system, so they dilate. When they dilate, just like I just showed you here, They become, instead of this big, they're this big, and now you end up with distributive shock. Okay. Now over here, anaphylactic shock, we've talked about this a lot. So anaphylaxis is an extreme type 1 hypersensitivity reaction, which is the same as asthma, by the way. And so what happens is your body will recognize a foreign antigen. In my case, like I said, it's nuts. Could be ants or peanuts or wasps or bees or whatever. And so occurs when people react violently to a substance to which they have been sensitized. Sensitized. So what has to happen is they have to be exposed to it at least once. Tricky question. So here it is. Is it possible for someone to have an allergic reaction the very first time? For sure, the very first time they've ever been stung by a bee, it's not. It has to be on the second exposure. They have to form antibodies from the first time they're exposed to the antigen. Okay, kind of a tricky way to test that. That's probably more medical school level, but I'm just telling you, it's an interesting phenomenon. Okay, now, so they've been exposed to something the first time they were stung by a bee, and their body's like, "Ooh, wow, this bee's pretty bad. We should like go full nuclear if this ever happens again." And so the body will build antibodies that will say, "Okay, next time a bee stings us, we're going to war. We're going to nuke them. We're going to go full North Korea on them." And so that's how that happens. Okay, and so it's like a nuclear level, just very exaggerated immune response. Dump everything you got. Okay, so this results in widespread vascular dilation, increased permeability, and bronchoconstriction. What's the mediator of these three? Histamine. Where is histamine released? It's eosinophils and mast cells. They carry histamine on them, and when they get the signal from a bee sting, they're like, dump it. And they just dump it into the blood. And so they dump all they got. And so it causes this widespread immune phenomenon. And we've seen histamine in local responses, right? So if I were to go up and just like slap your cheek, like your face, that cheek, and it's going to get red. The reason for that is histamine, because histamine it tells the vessels, vasodilate, allow red blood cells to come into the area and white blood cells to start healing, right? So imagine that across your entire body. And you can see the same phenomenon in hives. It almost looks like little, like not like fingerprint slaps, but like slaps across the body. It's histamine. It's causing vasodilation. Okay. Psychogenic shock, this can happen. So it's a sudden reaction of the nervous system that produces temporary generalized vascular dilation, resulting in fainting. So this can happen from moral disgust, surprise, startling someone. But if someone's like morally disgusted, they could also pass out from this. But it's a form of distributive shock. Okay. Shock occurs in two successive stages, right? So early shock, okay, or I'm sorry, compensated shock, and this is where we really try to catch them, because when you get into uncompensated shock, it's very bad. It's an early stage of shock. It's compensated shock. Obviously, the body's still compensating. It's doing what it has to do to try to get perfusion back where it needs to be. And then chemical mediators like epinephrine, dopamine, or epinephrine are released by the autonomic nervous system. Which side of the autonomic nervous system is it going to be? Which side releases dopamine, epinephrine, and norepinephrine? Sympathetic, right? Fight or flight, go fight a bear. Okay, you're going to want some dopamine and norepinephrine. What's pulse pressure? Okay, another formula. They wrote it out. So it's the systolic pressure minus the diastolic pressure. Not hard. So 120 minus 80. This is the systolic, this is the diastolic. What's the difference between that? It's 40. Okay, so that's the pulse pressure. Why does this become important? This could widen, okay, in certain types of shock, especially obstructive shock. So we use that sometimes clinically. Like, oh wow, they have a really wide pulse pressure. They might have obstructive shock. Okay, we use that. Oh wait, no. It narrows in obstructive shock. No, maybe it does widen. Got me second guessing myself today. It's okay. All right, decompensated shock. Late finding. What would you expect to find in decompensated shock? Is the blood pressure going to be the same, normal, or less? Or wait, high, normal, or low? It's going to be lower, right? So this is when you start decompensating, okay? So there, it's a late stage of shock. The blood volume decreased by more than 30%. So remember, we started with 6 of these. You've lost 2 of them. Okay. The compensatory mechanism begins to fail, of course. And then we will end up in irreversible shock. This is terminal, right? Like they're going to die at this point, unless like something really miraculous happens. So the shock has progressed to a terminal stage. Terminal means like near death. Arterial blood pressure will be very low, abnormally low. Remember, notice now is the first time they're mentioning blood pressure. It's a late finding. It's a late finding. And the reason I say this, guys, is because I have taken so many patients to the hospital, and nurses are like, no, their blood pressure is 133 over 85. They're not in shock. And it's like, yeah, they are. Okay? Yeah, they are. They're just not in irreversible shock or like late stage shock, but they're still in shock. They're still septic, right? They still have septic shock, or they still have whatever shock I was identifying. So, it wasn't my place, and I didn't then, and I'm not going to now, to argue with the nurse or educate them. Just know for yourself, know for me, it is a late finding. So you're going to have people that'll push back and be like, well, their blood pressure is good. Well, good. They're compensating still. Okay. Another thing, I'll plant this seed. What if their blood pressure was normally 170 over 100 and now it's 130 over 80, right? Did you know that it was normally 170 over 100 prior to their septic shock? You know what I'm saying? So there's things that we could discuss on this, but just be aware. Blood pressure, you should not hang your hat on blood pressure with identifying the early stages of shock. It's just not a good tool. Okay. Life-threatening reduction in cardiac output, blood pressure, and tissue perfusion will be found in irreversible shock. Obviously, you're knocking on death's doorstep at this point. You're about to die, or the patient's about to die. So what do we do about this? We do what we always do. We do our scene size up. We look for hazards. We make sure that we're safe. The patient's safe. Remember, safety is number one. Okay. So we do a primary survey. So we're going to do our full head to body or rapid full body scan of the patient. We're going to identify and manage any life-threatening concerns like the blood that's shooting out of their arm, or the fact that they're not breathing or something like that. Quickly assess the airway to ensure that it is patent. Quickly assess the patient's breathing. Assess the patient's circulatory status. Okay. If the patient shows sign of hypoperfusion, not you, but someone is going to try to gain IV access and treat aggressively with IV fluids. Think about what I just told you. Other than cardiogenic shock, the treatment is IV fluids. For distributive shock and for the initial treatment is for distributive shock is IV fluids, and for hypovolemic shock especially. Okay. So we take a history, determine the patient's chief complaint. Oh, I was stung by a bee an hour ago. Oh, he fell off the roof head first, hanging Christmas lights. Neurogenic shock. Obtain medical history. Okay. Oh, wow, they're taking like 10 medications. I should figure out if any of these are going to, interfere with the patient. I'll give you an example. It's a good example. It's a little extra. Don't memorize this, but there's a medication called metoprolol. I told you about it in the previous lecture, and it's a beta blocker. And this medication is designed to keep your heart rate less than 100 at all times. Okay. Well, what if you have someone who's in shock who's taking metoprolol? Can their heart rate get above 100? Not really. So you would be like, oh, wow, they look like they're in shock, but their heart rate's like 92, 95. It should be like 130, 140 before the blood pressure starts really dropping. And so just be aware of that. So there are medications that block our immune response or our body's response to fight some of these. Okay, that's just an example of a medication interacting that we would want to know. So we're going to take a sample history, right? Signs and symptoms, allergies, past medical history, medications, past medical history, last oral load taken, events leading up to this. Blood thinners, again, we need to know their medications, right? Like metoprolol, or are they on Apaxaban or warfarin or heparin or something weird like that? Lovenox. Okay. Secondary assessment. This is when we get to start putting big hands on the patient, doing our full assessment. Okay. We do that. We repeat our primary survey. We do a full body exam. Okay. Looking at everything, looking at the back, rolling them, looking at the chest, looking at all the skin, listening, touching, pressing, palpating, auscultating, right? Obtain a complete set of baseline vital signs. Okay. That includes temperature and blood glucose at least once. okay? Almost always. And then use monitoring devices to quantify the patient's oxygenating circulatory status. How do we do that? We count respirations. We could also use capnography, but mainly we use pulse oximetry. Pulse oximetry is a really good way to know if our interventions are helpful. Reassessment. We're going to reassess. Keep checking the patient. Are they getting better or worse? Right? In shock, you might not be able to turn this around very quick, so you might anticipate they're going to get worse even when you're providing the right treatment. Remember, your treatment can be your treatment's not delayed, but the fruits of your labor, right? The results of your treatment can be delayed. The feedback from your treatment can be delayed sometimes, especially if they're really sick. Okay. Of course, we're going to focus on the cardiovascular system, right? If the heart's not beating, nothing else really matters. And patients in decompensated shock will need rapid interventions, of course. Okay. Keep in mind, especially as EMTs, there's nothing you can't do in the back of a moving ambulance. Just get the wheels turning. Just start driving to the hospital. Just go to the hospital. I see patients or not patients, EMTs and paramedics, especially paramedics, where they'll try doing like all the Lord's work in the back of an ambulance. And it's like, that's great, but you could have done this en route to the hospital. At the end of the day, we're in the business of taking people to the hospital. That's what we do. Okay. So how do we treat shock? It varies on the type of shock, right? But, you know, you're obviously going to have to control external bleeding, tourniquet, direct pressure, wound packing, right? Place patients in a position of comfort, or I do like semi-Fowlers is my go-to. Sometimes you don't have to lay them flat. Sometimes you have to do Trendelenburg. What's Trendelenburg? If this is the patient's head and this is their feet, Trendelenburg is when you elevate their feet. You like bring their feet up. Okay. Provide warmth. Okay, remember they're going to be shunting blood from their skin and their extremities to their core. So if they become cold, it creates this triad that makes it even worse. So put a blanket on them. Okay, keep them warm. We're gonna. If you're this is an advanced EMT PowerPoint, but if you're a paramedic or advanced EMT, yes, you would start an IV. In the golden hour, remember, well, you want to get them to the hospital within the first 60 minutes after injury. Sure, we'll roll with that. All right, provide initial management for shock. Manage the airway. This becomes repetitive, so I always hate this part of the PowerPoint. Administer supplemental oxygen, place them in a position of comfort, obtain vital signs frequently. If they're critically ill, how often do we obtain vital signs? 5 minutes, every 5 minutes. Obtain IV access if you're allowed to, and maintain their body heat. I'm not going to talk about IV fluids. I meant to delete that. Let me do this. This is talking about IV fluid, and I meant to take some of these out, and I totally forgot. It's okay. I talked about the treatments for each of these, but I will come here. EpiPens. I have an AVQ right here, right? So remember, we can assist with the administration of epinephrine as EMT basics if the patient's having anaphylaxis. So you just pull it out, follow the commands. You're going to remove this cap. This one happens to speak to you. And then you're going to place this on the lateral portion of the thigh. And then it does it. Okay. If when we're in lab, if we have an expired EpiPen, I would love to show y'all. I would love to show y'all shooting one of these into like a water bottle. The needle comes out really violently, so I'll show y'all in lab. It's really kind of cool. Okay. Psychogenic shock, you're just going to support the patient. Okay. Try to calm them down. Remove the offending agent. They just found out that their husband cheated on them and they passed out. Right. Moral disgust. Then remove the husband. Okay. Just remove them from the environment. Okay. Just stuff like that. The treatment of these I've covered, so I'm not going to beat y'all down with that. But that's it for this chapter. I hope it probably should have been a review because I've covered this quite a bit. So hopefully this reinforced some concepts for us. But yeah, that's it. I appreciate y'all's time and talk to you later.